Hi, I'm Allison Fauner, and today we will be talking about the principles of bioethics. So within all fields of medicine, including pharmacogenomics, it is important to consider the ethical implications of the decisions that we make, both in terms of designing an experiment and executing it, communicating the results, and then delivering care within the clinic. So considering all of the possibilities of the implications of our decisions can be daunting and a vague process. So today we're going to talk about a framework that you can use to apply to your decisions in designing your studies and in applying clinical care that can help you think about these issues and reach the most moral decision. So to do that, we'll first start with an overview, which is looking at two different frameworks that are complementary to each other. The first is the Belmont Report, which has 3 guiding principles, and the second is the Principles of Biomedical Ethics, which has 4 guiding principles. Then we'll talk about the definitions so that you can understand what each of these principles mean, and look at some examples within the field of pharmacogenomics specifically. Finally, we'll end with a very simple case study looking at clinical care, where we can start to think about how do we apply these principles to make decisions within pharmacogenomics research and its implementation. So by the end of this module, you should have an understanding of what the principles of bioethics actually are, and then start to experience how you can apply them to guide your pharmacogenomics research and its implementation. So let's start with an overview. We'll start with the Belmont Report, which was published in 1979. Now, the Belmont Report was released by the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. Now, this work was done as a consequence of a series of transgressions to human subjects research. So you may have heard about the Tuskegee syphilis trial, in which African American men who had syphilis were not treated for their condition, even though a treatment was available, so that researchers could study the course of this disease. This is obviously not something that we want to continue to do. And so in 1979, the Belmont Report was released. And this was specifically designed to guide human subjects research. And there are 3 principles that the Belmont Report covers. This is respect for persons, beneficence, and justice. And we'll talk more about what all of those mean. The second series of principles was released by Tom Beecham and James Childress, also in 1979, in their book, Principles of Biomedical Ethics. Now, these principles were designed specifically for implementation in clinical medicine. And they are the respect for autonomy, non-maleficence, beneficence, and justice. But if you see, these 4 principles are very similar to the 3 principles from the Belmont Report. So respect for autonomy is the same thing as respect for persons. Non-maleficence, the idea that you don't do bad, and beneficence, the idea to do good, is about the same thing as just beneficence in general from the Belmont Report. And then justice from Beecham and Childress is the same thing as justice from the Belmont Report. So let's go through each of these principles, specifically looking at Beecham and Childress' 4 principles so that we can get a better understanding of how each of them works. And then we'll look at examples in pharmacogenomics that apply to each of these 4 principles. So by combining the Belmont Report and Beecham and Childress' 4 principles of bioethics, we have a framework through which we can consider ethical issues in human subjects research and also clinical medicine. So let's start with respect for autonomy. Respect for autonomy is the idea that we protect and promote the ability of a person to act intentionally and freely. So patients and research subjects should be able to do what they want, and they should have all of the information of the risks and the benefits of participating or receiving a treatment to make these decisions. So what are examples in pharmacogenomics related to respect for autonomy? A big one is the informed consent process. And the informed consent process was developed in response to these principles in order to give research participants full understanding of what they are about to get into. A second consideration in pharmacogenetics also relates to informed consent, in that we have an absence of coercion in study participation. So for example, if somebody is going to receive an inordinate amount of money for participating in a research study, that may be considered coercion and something that we should give a second think about in designing our studies. A third example comes to play a lot in biobanks. So an individual has a choice of whether to share information, and then on a clinical end, whether they want to receive information. So this comes to play a lot in genetics if people actually want to receive the genetic test results or not. Our second principle is non-maleficence. Non-maleficence is the idea that we do not intentionally inflict harm. So this can be through either actively inflicting harm or by producing harm by not acting at all. This can be at the scale of the individual. Do we harm an individual person? Do we harm the communities that this person is part of? Or do we harm society in general? So examples in genetics and pharmacogenomics where non-maleficence may be a consideration is that we always want to minimize the risk of stigma or discrimination. Now this issue is a little bit less of a problem in pharmacogenomics because how somebody responds to a medication is not as stigmatizing as, say, risk for a disease. But this can be a consideration in our study designs. We can also run into considerations of non-maleficence related to giving incorrect medical advice. So for example, if a patient receives a genetic test that only looks at very specific markers, they may be reported to be a normal metabolizer for a drug, whereas if the panel had looked at other markers in a gene, it may turn out that this person is actually a poor metabolizer or an extensive metabolizer that could have pretty serious implications for drug response. The problem in pharmacogenomics is if this test is done, a patient is given the wrong information, and then that result travels with them through the course of their lifespan. They could continue to be getting these wrong medical decisions as a result of this incorrect medical result. A final consideration is that medical conditions that are associated with or an LD with a variant that we're looking at in pharmacogenomics could have wider implications for the patient. So for example, the ApoE4 allele has been implicated in different response to statins. So if a patient is tested for their ApoE4 allele in trying to optimize their statin dose, it could also give information about Alzheimer's risk. And that, going back to our previous definition of respect for autonomy, may not be something that this person wants to know. So our third principle is beneficence, the idea that we provide benefit and contribute to welfare. We do good. And again, this is at the level of the individual, the community, and society. I think the principle of beneficence is the easiest one to understand because it's the foundation that medicine is built on. We want to optimize medical care, give the right drug to the right person at the right time, and improve clinical outcomes. The fourth principle is justice. And I think justice is really interesting because it's the promotion of fair distribution of resources, benefits, burdens, and services, not necessarily the equal distribution. So if we look at examples of how this can come to play in pharmacogenomics, we can see that justice is ensuring that all people have access to the benefits of pharmacogenomics. Now, on the research level, this means including diverse communities in research. If we're only doing research in a subset of people, we're not going to know the full extent of variants that can affect pharmacogenomic response. This also means that we deliver medical care that is accessible. So all people should have access to pharmacogenomic technology, regardless of their socioeconomic status, their geography, or anything else. And finally, and this is related to making sure we include diverse communities in research, we want to make sure we develop medical interventions that are optimally effective for diverse patients. So if we only include a subset of communities in research, then whatever medical interventions are developed as a result are also optimized for that population. And that would not be upholding this principle of justice. Finally, an additional consideration is that resources in medicine are limited, and we want to make sure that we are allocating these resources to the causes that need them the most. So you can see that all of these issues are complex and nuanced, and they maybe don't all agree at the same time. And that's where the principles come into play as a framework for making decisions, not rules that you have to adhere to. So all the principles have equal weight, and when they don't all converge on the same moral decision, you consider each principle in context of the specific situation with complete and accurate information, so that these frameworks provide a way to think through the issues and think through what decisions you want to make without being binding in any way. So what's an example of how we can apply this framework in a specific instance? So we'll look at a very simple clinical case where we have our patient Kevin who's being prescribed allopurinol for gout. Now, if you remember from previous lessons, 55 to 100% of patients with the HLA-B*58:01 allele will develop a severe hypersensitivity reaction to allopurinol. If patients don't have that allele, then they only have a 1.5 to 15% risk of developing hypersensitivity reaction. Now, important consideration in Kevin's case is that insurance will not pay for the genetic tests. So how can we apply this framework of the 4 principles of Beecham and Childress to decide how to approach Kevin's care? So let's start with our first principle, respect for autonomy. Now, a few things we might want to consider, again, this is not everything that we could think of in this situation, is that making sure Kevin is given the choice of whether to receive treatment or not. Is Kevin given all the facts of the risks and benefits of receiving genetic tests? And then, is he given the choice of deciding what he wants to do with whatever result he gets? How do we want to share this information? Do we want to keep the information in the medical record? Do we want to only use it this once for this one treatment? Does he have other family members who may benefit from knowing what their risk chance might, or what their risk allele might be? And then what does Kevin want to do what does Kevin want to do as a result? So if Kevin does have the HLA-B*58:01 allele, but he wants to take allopurinol anyway, for example, allopurinol is cheaper than an alternative drug, that should be considered as part of this respect for autonomy. Let's apply our second principle, non-maleficence. Don't do harm. So what are the potential harms that could be caused by clinical care in this context? So without performing genetic testing, Kevin is still exposed to this greater risk of a hypersensitivity reaction. Looking at resources, how is Kevin going to pay for this test? If he doesn't pay for the test, what could he use that money for instead? And then this alternative drug, febuxostat, is also associated with hypersensitivity reactions in some states. But we don't understand the risk factors for hypersensitivity reaction to that drug as well as we understand allopurinol. So if Kevin does have this risk allele and we give him a different drug, what happens if he also has instead has a severe reaction to that drug? Again, you can see that these all are hypotheticals and some are more severe than others, but in this state we can brainstorm what are all the possibilities here so that we can weigh them later. Finally, the beneficence principle. So in providing a genetic test to Kevin, we can provide him the best care. If he has the HLA-B*58:01 allele, we can give him a different drug and reduce his risk of developing hypersensitivity reactions. If he doesn't have the allele, then we can give him allopurinol. It'll be cheaper for him, and he has a lower risk of developing hypersensitivity. Finally, the Fair Access and Distribution Clause. Now, in clinical care, this can come to play as if Kevin can't afford to take this test, and so we're, as clinicians, guessing what drug to give him, how he might do on allopurinol. He won't receive as good of care as someone who is able to afford the test and make decisions with all of the information that's available. So as we think about what we want to do in Kevin's case, I think it's pretty clear that there's a significant benefit to giving Kevin this genetic test. But if we go back to our first clause of respect for autonomy, if Kevin doesn't even want to take this test, he doesn't want to pay for it, then that can shift the balance in favor of a separate decision that would be most morally responsible. So in conclusion, we have 4 main principles of bioethics that can be used to guide clinical decision-making and human subjects research. These are respect for autonomy, non-maleficence, beneficence, and justice. We can use this framework to think through our decisions and make sure we are ending at the most morally responsible decisions in each case.